Morning, students. My name is Dr. Shubh. I am a first year resident from Orthopedics Department, and today we'll have a brief class on peripheral nerve injuries, and to be specific, on foot drop, lateral popliteal, and sciatic nerve injuries. So, first of all, may I know if any one of you has any idea or some sort of idea regarding nerve injuries or foot drop? And would anyone like to initiate the conversation in the class right now, or should I go ahead with the class myself? I would like one of you or some of you to take the initiative and start discussing the topic. May I please have someone from amongst you to talk about foot drop? Anyone? Or nerve injuries? So, first of all, before discussing the nerve injury, we need to know what is the basic structure of the nerve, so as to get an idea how the injury happens, right? So, first of all, to discuss the basic structure of the nerve, we have the key elements like axon, myelin sheath, endoneurium, perineurium, and epineurium. Now, axon is the core functional unit of the neuron which conducts the electrical signals, which is a very basic thing which we are learning since our school days. Then comes the myelin sheath. Similarly, it covers the axons and it speeds the conduction. You might know about the saltatory conduction, nodes of Renvier, stuff like that, which helps the faster conduction of nerve signals. And then comes the three layers. Now, this is very important to know about the injuries which can occur to the nerves. Endoneurium, perineurium, and epineurium. Endoneurium is the connective tissue surrounding each axon. Perineurium encloses bundles of axons, and the outermost part is the epineurium. Now, to know the injuries, we have two basic and key classifications to bifurcate the type of nerve injuries. First of all, the classification is the Seddon's classification, and the second classification is the Sunderland classification. As you can see on your screen, the Seddon classification has been divided into three parts: neuropraxia, exontomesis, and neurotomesis. Right? Now, in neuropraxia, there is just local injury to the axon. Right? The axon which is covered by the myelin sheath, there is just local injury. It is not that extensive. So there is just scraping off or minute injury of the myelin sheath in neuropraxia. As you can see, in layman terms, you can call it compression and nothing else. Right? Then comes exontomesis. As the term suggests, the axon is now involved. The myelin sheath has been breached, and now the nerve injury has reached to the axon. And then comes neurotomesis. That means the entire nerve has been disrupted. Now, that is a very briefly classified Seddon's classification. Sunderland went a little further and divided the classification into 5 parts: 1, 2, 3, 4, and 5. Now, the neuropraxia, as Seddon called it, is similar to Sunderland's classification grade 1, right? Where, as I told, only the myelin sheath is injured. Some part, so a local area of myelin sheath will be involved and nothing much, which is called Seddon's classification. In Seddon's classification, it is called neuropraxia, and in Sunderland's classification, it is called grade 1. And the prognosis is excellent, as you can see, and the treatment is conservative. The patient recovers from it very soon. Now comes the rest of the classification of Sunderland, grade 2, 3, and 4. Now, when we talk about grade 2, 3, and 4, it corresponds to Seddon's exontomesis, right? Here the axon is involved, but Sunderland, classified it even further. Now, when we talk about axon getting involved, then we just discuss the parts in the previous slides, right? The endoneurium, perineurium, and epineurium. So, when just all the three layers are intact, right? Then it is grade 2. If the endoneurium is involved, right, then it will be grade 3. and endo and perineum, both the layers are involved, then it will be grade 4. And as we go on further from grade grade 2 to grade 4, the prognosis decreases, and in grade 5 there will be complete disruption of the nerve, and which will correspond to Seddon's neurotomesis, right? And in last grade, that is grade 5 or Seddon's neurotomesis, we will need surgical intervention to repair the nerve injury. Would you like, is anyone of you having any doubt or want more idea regarding the classification or the nerve injury as far as the two slides are concerned? Okay. Now comes the volunar degeneration. Now, volunar degeneration is part of a nerve injury and nerve recovery, and it generally occurs in it won't occur in neuropraxia, but it will only occur in exontomesis and neurontomesis. So it is one of the factors which helps us to classify the nerve injury and differentiate the nerve injury. It begins after 24 to 36 hours of the nerve injury. Here the axon is it starts degenerating distally, not proximally. You should keep this in mind. The axon starts degenerating distally, and then after the degeneration happens, as we know, there are cells called macrophages in our body which will clear the debris, and the Schwann cells which create the myelin sheath and other structures around the nerve, they help the guidance of regeneration. Now, if the volunar degeneration occurs but the pathway is intact, right, then there is potential of regeneration. But if the pathway is not intact, then the prognosis is poor. And there are nerve conduction studies, electromyographies, which are generally done after, as you can see, the Schwann cells help the guidance regeneration after 1 to 3 weeks, right? So that is the time after which we do nerve conduction studies and electromyographies, so as to get a better idea regarding the nerve status. So the idea and the phenomenon of volunar degeneration is very much useful in application of techniques like nerve conduction studies and electromyographies. Then the clinical features of nerve injury. Now this is a very basic thing. Whenever we get a nerve injury, what are the functions of nerves? Basically, there will be a motor function, there will be a sensory function, right? So those functions will be decreased or it will be lost. So the motor function, if the motor area is involved, then there will be weakness, paralysis of the supplied muscles, sensory loss or altered sensation in nerve distribution, and reflexes will be lost or will be absent or will be decreased, and trophic changes like muscle wasting, like the muscle strength, the muscle strength will decrease, the muscle nutrition will decrease, right? And the Tinel signs. Now this is also a very important phenomena. It is a very important way of clinically examining a nerve injury. When you tap across the... No, please don't disturb me. Have a seat outside and study the same topic. Okay. Now, the Tinel sign. It is a very important way of clinically examining a nerve injury. Sorry. Now, when you tap along the pathway of the nerve, when you do percussion along the pathway of the nerve, there is a tingling sensation, right? So that helps us to signify if the nerve is intact or not, if the injury has happened or not. Now, going into specifics, lateral popliteal nerve injury, which is also called the common peroneal nerve. It is a branch of sciatic nerve. It winds around the neck of fibula and is superficial and vulnerable to injury, especially due to trauma or compression. Right. So, as the anatomical pathway, the brief pathway which I have mentioned here, it is very common. Like whenever it is very easy to understand that whenever there will be a neck of fibula fracture or head of fibula fracture, then there will be a risk of common peroneal nerve injury, right? Now, let's go into more. Please go outside. right? What is the intention of coming to class? Do you want the attendance or do you want to study? Yeah, then study outside. You have your books, right? You have your phones. Then study. Please, I'll give you 5 seconds. Please close the door. There is a good sofa outside. Sit there and study. Okay. So yeah, the origin of this common peroneal nerve will be in the popliteal fossa. It is the branch of the sciatic nerve, and as I told, it winds around the fibular neck, and then it further divides into the deep peroneal nerve and superficial peroneal nerve. Deep peroneal nerve goes to the anterior compartment of leg, and the superficial peroneal nerve goes to the lateral compartment of the leg. Now, the as we are discussing the injury, then what will be the cause of this injury? As I told, trauma, right? As I told, the fibula fracture, so trauma. Then knee dislocation. The neck of fibula, the head of fibula is very much around the knee joint, right? So the knee dislocation, especially the posterior lateral one, and laceration, penetrating injuries, any injury around or in and around the knee joint, in and around the proximal aspect of the leg, can cause lateral popliteal nerve injury or the common peroneal nerve injury. Compression. Now, whenever there is a fracture, whenever there is a injury outside, we'll do some dressing, right? We'll apply some plaster, we'll apply some cast, slab, etc. So, if it is applied in a way that it is causing more amount of compression, more amount of pressure, then also it can cause common peroneal nerve injury. Prolonged squatting or cross leg sitting. Bedridden patients with prolonged external pressure. Surgical causes of injury, or we can also say the when the patient undergoes a total knee arthroplasty or high tibial osteotomy. Basically, the surgeries involving the proximal aspect of leg, the knee joint. Then it can also cause common peroneal nerve injury. And again, the idiopathic cause, neuropathy at the fibular head, compression, etc., can cause common peroneal nerve injury. Now the clinical feature. The classic feature of common peroneal nerve injury will be the classic presentation as far as the motor aspect is concerned will be foot drop. As the name suggests, the foot is dropping, right? So it won't be able to plantar flex. This will be plantar flexion and this will be dorsiflexion, right? So we won't be able to do plantar flexion. So, I would correct myself. We won't be able to do the dorsiflexion. Like this will be the dorsum, right? This is the dorsal part. So we won't be able to do the dorsiflexion, and the foot will be in the plantar flexion position. So we'll have loss of dorsiflexion, and there is the classic presentation when the patient walks, right? As the foot will be in plantar flexion. If the patient won't be able to dorsiflex it, it will be very much in a loose state. So whenever the patient walks, he has to like lift the leg properly and then put it on the floor to make a step ahead. So it will be more like a stepping gait, like the patient, as if I can try and demonstrate, I hope I demonstrate in a proper way. So if the patient is walking, right? So if the patient is having the plantar flexion, right? He is not able to dorsiflex the foot. So if the foot is continuously in this state, if I have to walk, so I'll do this, then I'll again bring my leg upwards. It will be like a stepping gait. I'll have to take huge steps to move further. So that is a classical presentation of a patient with common peroneal nerve injury where he is not able to dorsiflex, right? The muscles affected, the main muscle which helps in the dorsiflexion is the tibialis anterior. So that will be the most affected one. And then the extensor digitorum longus, extensor hallucis longus, peroneus longus and brevis. These are the muscles which will be affected in the common peroneal nerve injury. Now the examination. Motor testing. Ask the patient to dorsiflex and invert the foot. So the patient will not be able to do it. It will be very difficult or impossible for the patient to do it. Sensory testing. or lateral leg and dorsum of the foot, and tunnel signs. As I told, we have to tap along the pathway of the nerve, which out here is the fibular neck. It will produce the tingling sensation. Sorry. Now the investigations, the nerve conduction study, electromyography for localization and prognosis, MRI in case of suspicion of root pathology. What do you mean by root pathology? Now there are nerve roots, right, around the spinal cord from which the parent nerve arises and then the branches go on further. So if there is some sort of disc compression, disc prolapse, because of which there is compression around the root, then it can eventually lead to nerve pathologies around the path ahead. So we can do MRI to rule that out, and ultrasound to identify compression sites or mass lesions. Now the management. If there is injury, we will have to manage it. So first, it can be conservatory, where you can ask the patient to rest. Then ankle foot orthosis. It prevents foot drop. It's basically have you seen patients with below knee slabs, plasters, whenever they have fracture of the lower limb? In certain fractures, we apply below knee plasters, which are L-shaped. So if this is the leg, so the plaster will be here and here, which will be covering the sole and the posterior aspect of the leg. The ankle foot orthosis is very much similar in shape, and the patient is asked to wear it so as to place the foot in dorsiflexion, right? Then physiotherapy, treat the underlying cause if there is any. Surgical intervention, nerve decompression, nerve repair and grafting, tender transfer, where the tibial is posterior transfer for the foot drop is done. Now the next injury for which we are going to discuss today is the sciatic nerve injury, right? It is the largest nerve in the body, formed by the L4 to S3 nerve roots and supplies most of the lower limb. Injuries to it can result in devastating motor and sensory deficits, especially affecting the posterior thigh, leg and foot. Origin is from L4 S3, as I told, from the sacral plexus. It exists the pelvis via greater sciatic notch, passes beneath the piriformis muscle. Now this is an important aspect as far as a pathophysiology called piriformis syndrome is concerned. You should remember this fact that the sciatic nerve passes beneath the piriformis, and in certain anatomical anomalies, the nerve can pass through the fragments of piriformis or in between the piriformis. So if these are the fibers of the piriformis, then the nerve will be passing within the muscle, because of which if there is a contraction of piriformis, there will be nerve entrapment, and it will cause pain to the patient. And it bifurcates at the popliteal fossa into tibial nerve and common peroneal nerve. Again, causes the classic 4-5 criteria: trauma, iatrogenic cause, compression, tumor, and idiopathic or miscellaneous causes. Trauma will be posterior hip location, pelvic fracture, and femoral shaft fracture. Out there, it was fibular fracture in common peroneal nerve. Iatrogenic causes or surgical causes: hip surgery. Out there, it was knee surgery. Here, also intramuscular injection in the gluteal region can cause sciatic nerve injury if not given in the proper area. What is the zone at which we give IM injections in gluteal region? Here, upper and outer quadrant, right? Now compression. As I told, piriformis syndrome. If the patient has habit of sitting for prolonged hours, then it will cause piriformis syndrome, where the nerve which passes beneath the piriformis, that is the sciatic nerve, it will get compressed. Or if there is anatomical anomaly where the nerve is passing through the muscle and the muscle contracts, then also the patient will experience pain. Hematoma, prolonged immobilization, tumor like schwannoma, neurofibroma, pelvic masses, endometriosis, gunshot wounds, radiation neuropathy are other causes of sciatic nerve injury. Clinical features: weakness, paralysis of hamstring, leg and foot muscles, foot drop, again because the nerve goes on further and divides into common peroneal nerve and tibial nerve. So this will also cause foot drop, loss of ankle jerk, sensory loss, and pain, which in layman terms is called sciatica. Examination: SLR straight leg rest test, positive in sciatica. When you ask the patient to raise the leg without bending the knee, they'll experience pain. It will be a positive test. Motor testing: dorsiflexion, plantar flexion, and knee flexion. The patient won't be able to dorsiflex if the peroneal part of the peroneal branch is also involved in the injury. Reflexes: absent neck, ankle jerk. Sensory testing around the posterior thigh, leg, and foot. Again, the same high step edge gait here also. Right? Investigations of MRI pelvis, lumbosacral spine, nerve conduction studies, X-ray, CT if there is any trauma. Now there are two divisions of the sciatic nerve as we discussed, right? The tibial one and the peroneal one. The tibial division, in the tibial division, the muscles involved are hamstrings, except the short head of biceps femoris, the plantar flexors, toe flexors, and the sensory loss is around the sole of the foot. In the peroneal aspect, we have muscles like short head of biceps, dorsiflexors, everters, and sensory loss is around the dorsum of the foot and lateral leg. Now the management of this injury. As we told, there are two types, conservative and surgical one. The physiotherapy, there is ankle foot orthosis as I mentioned before, pain control and treating the underlying cause. And the surgical management will be nerve repair and grafting, decompression and exploration of the nerve and then correcting it in case of persistent post THR, that is total hip replacement palsy. Now we'll discuss foot drop in general and then we'll wind up the class. Foot drop is not a diagnosis as such, it is a clinical sign defined as the inability to dorsiflex the foot as we discussed, leading to step edge gait and dragging of the toes while walking. Foot drop is a condition where the dorsiflex muscles, primarily tibialis anterior, extensor hallucis longus and extensor digitorum longus, are weak or paralyzed, resulting in inability to lift the foot during swing phase of the gait. Key muscles involved as we discussed, tibialis anterior, EHL and EDL. Causes: peripheral nerves, the nerves which we discussed, common peroneal nerve, sciatic nerve, deep peroneal nerve. The most common will be common peroneal nerve around the fibular neck. Central causes like stroke, especially the cortical lesions, cerebral palsy, brain and spinal cord tumors. Muscle and tendon problems like anterior compartment syndrome, muscle dystrophies, lacerations of the anterior compartment. And the surgical causes like TKR, DHR, improper cast application, cross leg sitting, etc. Would anyone of you like to discuss compartment syndrome in brief? Does anyone have any idea regarding compartment syndrome? Okay, so this will be, if you are interested, obviously, this can be your homework for the day. Study compartment syndrome. It is a very short topic, so you can do that. Clinical features of foot drop we have already discussed. Weak dorsiflexion, toe dragging and sensory loss, gait, abnormal gait, right? And internal signs will be positive around the fibular neck. These are the investigations and the management like tendon transfer, ankle foot orthosis, physiotherapy, nerve decompression. Now there are other common nerve injuries. I guess you have a class tomorrow regarding radial nerve or something like that. So nerves like axillary nerve, radial nerve, medial nerve, ulnar nerve, femoral nerve, sciatic nerve, common peroneal and tibial nerve. These undergo common peripheral nerve injuries which eventually lead to, like axillary nerve will lead to deltoid paralysis, right? We have the regimental badge area around the shoulder and there will be loss of shoulder abduction. Then the radial nerve will have this drop, medial nerve will have ape thumb, deformity, ulnar nerve will have claw hand, right? So these are the classical one-liners or MCQs or short notes which can be asked to you in any of your exams. If you have any question, then we can discuss, or else we'll wind up the class. Anyone?